Okay guys, so we have two short presentations on interpretation of the chest radiograph for you. The first one will take you through a systematic approach to the interpretation of the chest x-ray, and then the second one, and during the second video we will look at a series of cases and discuss the abnormalities on those x-rays. So the objectives of this talk are to help you understand the systematic approach to reading a chest x-ray, to identify normal structures on the chest x-ray, and to identify common abnormalities on chest x-ray. And the systematic approach is what we would call an ABC approach. The A stands for alignment and adequacy, B for bones and joints, and C for cartilage and soft tissue. Prior to going into detail of the chest x-ray, you need to make sure that you've identified both the x-ray and the patient correctly. So check the patient details, the name, date of birth, gender, and also consider what you know about the patient before you look at the x-ray. Then you look at the x-ray. Make sure it's the correct film. Look at the date and time. This could be really important with chest x-rays in patients with chronic respiratory conditions, for example. Make sure that you're looking at the correct part of the body and determine what orientation the x-ray is. It an AP or PA when it comes to a chest x-ray, or possibly a lateral? And then make sure you know what type of study it is. Is it a plain study or a study with contrast, or it is some kind of special study such as a tomogram, for example. What do we mean by adequacy and alignment? Well, are we seeing enough of the chest? A chest x-ray should extend from the lung apices right down to just below the costophrenic angles, and laterally out far enough that it includes the outer margin of the lateral chest walls and the shoulders. The exposure can be assessed by looking through the heart at the vertebral bodies, which should be just barely visible through the density of the heart. And finally, you can check for rotation by looking at the spinous processes of the vertebral bodies and seeing if they are equidistant from the medial ends of either clavicle. The bones and joints are not really usually the focus of a chest x-ray, so it actually is worth looking at them first just to make sure you're not going to miss anything obvious. Look at the ribs. You actually trace down each rib in turn, looking for fractures or lysis or callus. But also look at the intercostal spaces, because if they are smaller on one side, this might mean poor lung expansion on that side. Conversely, if they seem more spaced out, it might mean that you have hyperinflation of the lung on that side. And then look at the other bones and joints, such as the clavicles, the vertebrae, and the shoulders for obvious injuries, fractures, dislocations, that sort of thing. The main focus of the chest x-ray is the cartilage and soft tissue, and you need to look at it systematically. Either go from inside to out or from outside to in. I actually prefer going from inside to out, but when you do that, remember to look all the way out to the soft tissues of the chest before giving a full interpretation. So start with the mediastinum, look at the heart, the great vessels, the hilar regions, and the retrocardiac space. Then you look at the lungs for texture, size, the degree of expansion, and any focal abnormalities. Look at the pleural spaces to identify any effusions, any thickening or pneumothoraces, and then the subcutaneous tissue fat, where you might see things like subcutaneous emphysema or subcutaneous edema. This picture is a normal chest x-ray, and it's just to kind of correlate the normal x-ray with the anatomy of the chest. So if you look at the cardiac silhouette, the left border of the heart is made up of the left ventricle lower down and then the left atrium higher up. whereas the right atrium makes up the right border of the heart. And the heart is situated such that about 1/3 of the diameter of the heart is to the right of the vertebral bodies, whereas 2/3 is to the left. You can see the carina and the angle. The carinal angle is normally 60 degrees, but it certainly should not be more than 90 degrees. If it is that wide, then you need to think about something at that level splaying the carina, such as enlargement of the left atrium. The aortic arch shows as a knuckle just to the right of the carina, and the trachea is centrally placed with a small sliver of the superior vena cava to the right of it. And in fact, this is something that we look for when we're looking for subtle signs of either consolidation or collapse of the apices of the lung. That little white stripe on the right side there is lost if there is consolidation adjacent to it. We look at the costophrenic and cardiophrenic angles to make sure that they are sharp and well demarcated. If they aren't, that might suggest the collection of fluid or possibly the presence of consolidation in that area of the lung. And of course we look for the normal lung markings, which should reach outward almost to the lateral border of the chest. And if they don't, then we should look closely to see if we can identify a pneumothorax. So in conclusion, the systematic approach to the chest X-ray consists of looking at the alignment and adequacy, bones and joints, and cartilage and soft tissue. We've had a look at a normal chest X-ray, and now we're going to proceed in the next talk to look at some common abnormalities you may encounter. Thank you.